Jeremy Kessler is double certified in family medicine and preventative medicine. Jeremy completed a family medicine fellowship with a focus on leadership and faculty development. He subsequently completed a wilderness medicine fellowship at Virginia Tech Carilion School of Medicine and has since transitioned to faculty with an academic appointment as adjunct professor with the University of Utah School of Medicine. Jeremy went on to complete a third fellowship in undersea and hyperbaric medicine at Advocate Aurora Health in Milwaukee, Wisconsin. He transitioned into the medical director role at Ogden Regional Medical Center from August 2022 through January 2025. As of January 2025, Jeremy has transitioned into his role of medical director for advanced wound care and hyperbaric specialists in Layton, Utah. The time is Dr. Kessler's.
Hey, good morning, everyone. All right, thank you so much for this opportunity. I'm Jeremy Kessler, a wound care and hyperbaric physician. I'll be here all day at a table outside set up, so if we have any questions for further deeper dives, I'm available. No financial conflicts to disclose. Here are our learning objectives that we'll discuss today. So the goal, global approach taken towards optimizing wound care patient, we focus on smoking cessation and glycemic control in our diabetic patients. Infection control with topical or oral antimicrobials helps eradicate colonization or any lingering infections. Serial debridements to remove all necrotic tissue stimulates new tissue growth. Improving protein intake is paramount. Removing any pressure, shear forces, or friction rubbing while optimizing blood flow to and from the wounds. We paid close attention to each patient before us, and there are 15 FDA-approved indications that allow us to add hyperbarics as another treatment modality. We use two medications in HBO, oxygen and pressure. Medical-grade oxygen will fill the chambers at close to 100%, and we choose different treatment depths depending on the indication before us. While sitting at sea level, the atmospheric pressure is 760 millimeters of mercury, or 1 atmosphere absolute, referred to as ATA. As one travels down to a depth of 33 feet of seawater or 34 feet of freshwater, the atmospheric pressure doubles. The treatment profiles dictates the partial pressure of oxygen while mitigating the risk of oxygen toxicity. Now let's relate this to altitude. Diving and altitude are a continuum of atmospheric pressure. The air you breathe at depth versus on the top of Mount Everest are the same constituents, 21% oxygen and 79% nitrogen. What changes is the atmospheric pressure. When I volunteered at Everest DR and the Himalayan Rescue Association, we set up a clinic at base camp just under 18,000 feet. The atmospheric pressure is half that of sea level. Our pulse oximeters were in the low 80s at rest. Those who went on a summit Everest, which sits just under 29,000 feet, the atmospheric pressure is 1/3. I would bet that most of you have been inside a hyperbaric chamber without realizing it. Every time you fly in a plane, you step foot inside a hyperbaric chamber. A commercial aircraft typically flies at 35,000 feet above sea level, and the cabin is pressurized to approximately 8,000 feet. This is why if the cabin of a plane was to suddenly lose pressure and go from 8,000 to 35,000 feet instantly, the instructions are to immediately put on your own oxygen mask before helping others. Why, you ask? Because hypoxia will set in very quickly when the cabin decompresses, making it impossible to make goal-directed, cognitively sound decisions. So let's transition to the benefits of hyperoxygenation on the body. So breathing 100% oxygen supplementation at normal baric pressure or sea level, the oxygen dissolved in the blood is approximately 1.5 milliliters per deciliter. Breathing 100% oxygen supplementation at 3 ATA or 66 feet of seawater, the oxygen dissolved in the blood is approximately 6 milliliters per deciliter. That's enough dissolved oxygen to satisfy resting cellular requirements without using circulating oxygen bound to the hemoglobin. So in 1955, Dr. Ida Burma, a cardiothoracic surgeon, began using hyperbaric oxygen during surgical corrections of anomalies such as transposition of the great vessels and tetralogy of Fallot. His experiments proved that under hyperbaric conditions, there was an increase in tissue oxygen stores, providing an extension of the respiratory reserve, preventing irreversible hypoxic damage to the cardiac tissue. Dr. Burma's monumental study, Life Without Blood, involved exsanguinating pigs by removing all circulating whole blood while replacing it with plasma. The pigs were subsequently compressed down to 3 ATA, and during this observation period, they did not suffer from hypoxic symptoms. This proved, as a result of hyperbaric exposure, the elevated levels of oxygen within the circulatory flow was not erythrocyte dependent. The pig's whole blood was returned to circulation, and following decompression back to sea level, they all survived. This is when the application of HBO in clinical form began to gain traction. HBO increases mobilization of stem cells to migrate to open wound beds and expedite wound healing, promoting growth of new blood vessels. This is termed angiogenesis and vasculogenesis. HBO mobilizes and activates leukocytes and macrophages. Phagocytic killing requires a minimum of 30 millimeters of mercury of oxygen tension in the tissues. The minimum inhibitory concentration of an antibiotic is higher in a hypoxic environment. So hyperoxygenating a wound, the antimicrobials can have a more pronounced impact on the organisms due to increased rate of diffusion towards the infected area and a lower MIC needed to kill the microbes. The oxyhemoglobin dissociation curve shows a relationship between oxygen saturation of hemoglobin across a range of pressures. The solid black line shows the curve for normal adult hemoglobin. Left shifts of this curve represent conditions that increase oxygen affinity to hemoglobin, making delivery of bound O2 less at the level of the tissues. HBO assists by shifting this curve to the right, decreasing oxygen affinity for hemoglobin. This allows increased delivery of oxygen at the level of the tissues with exposed increased partial pressures of oxygen. So throughout the remainder of this lecture, try and think about this curve and how it will apply. This slide reviews the different treatment regimens we commonly use. Here's a checklist we review with each patient to mitigate risk. Exposure to high pressures of oxygen in a pressurized environment causes peripheral vasoconstriction, which centrally shunts blood towards the heart. Pre-existing CHF or arrhythmias can be exacerbated in the chamber, causing flash pulmonary edema. A pressurized environment can cause pneumothorax to develop or worsen one that exists. Psychosis and confinement anxiety are best known about prior to locking someone into an environment not easily escapable. HBO increases metabolism and therefore causes hypoglycemia, so we watch our diabetic patients closely. After the initial questioning, the workup can vary depending on the patient before us. 100% oxygen can have both therapeutic and toxic effects depending on the exposure time and the partial pressures of inspired oxygen. Hyperoxygenation on rare occasions can induce seizures. We see barotrauma of the ear quite often, and some patients require the replacements of myringotomy tubes. Hyperoxic myopia can be observed in patients undergoing prolonged periods of daily HBO. This will resolve within weeks to months following cessation of treatments. This is a chart of the TEED scoring system for otic barotrauma. Please feel free to reach out and discuss cases as we are available and excited to help. All right, so now we transition to the indications, non-urgent indications. We start with refractory wounds. Diabetics are classically affected with poor wound healing. Consider long-term poor glycemic control and the cascade of subsequent peripheral vascular disease and neuropathy. The following is a brief review of the Wagner grading system for diabetic foot ulcers. Grade 0, a high-risk foot. Grade 1, partial thickness ulcers without deep tissue involvement. Grade 2, deep ulcers that penetrate down to deeper structures such as the muscle. Grade 3, deep ulcers, osteomyelitis or deep abscess can be present. Diabetic foot ulcers that stall or deteriorate after optimization of the factors we reviewed earlier and 30 days of transpirative care are candidates for hyperbaric oxygen treatments if categorized as a DFU 3, 4, or 5. A DFU 4 is a localized gangrene, and 5 is diffuse gangrene. This is a classic patient we see in the hyperbaric department. With poor attention to these wounds, the patient could easily advance to a lower extremity amputation, and that would increase morbidity and mortality. Delayed radiation injuries. most commonly seen in radiation exposure of 5,000 to 6,000 centigrade or greater. Delayed radiation complications present after a latent period of 6 months to several years following exposure. The cascade of hypocellular, hypovascular, and hypoxic tissue result. Radiation may either kill a cell outright or inflict lethal damage so that it dies later. The surviving cells produce defective collagen or defective regulatory enzymes. The residual tissue develops a progressive loss of vascularity and cellularity over time. Radiated tissues do not spontaneously revascularize, which creates a shallow oxygen gradient of less than 20 millimeters of mercury. Therefore, the body does not recognize the radiated injury as a wound. In fact, the radiation effects of the cells make the tissue worse with time. Hyperbarics creates a steep oxygen gradient in radiated tissues which cannot develop naturally. The graph shows transcutaneous oxygen readings during serial hyperbaric treatments correlating to increased angiogenesis. The next series of slides comes from studies that identify oxygen tension is 5 to 10 millimeters of mercury at the center of a radiated wound. Note that as one reaches the limits of the radiated field, the normal 55 to 60 millimeters of mercury oxygen tension can be found. The increasing partial pressures of oxygen in the peri-wound creates an oxygen gradient to initiate angiogenesis. Following 10 hyperbaric treatments, oxygen gradients are observed to move centrally, indicating angiogenesis comes from the periphery and the deep wound margin lying outside the radiated field. Following 18 treatments, oxygen gradients are observed to continue to move centrally, eliminating at the periphery of the wound. At 24 to 28 treatments, the partial pressure of oxygen increases within the center of the wound, and the body now recognizes the wound and starts the healing cascade. This is when debridements of these wounds can be considered. Once we have reached this timeline of treatments, patients can return to their specialists for reevaluation and consider scopes with cauterization of bleeding mucosa, dental extractions, or any staged surgical intervention. Refractory osteomyelitis. HBO is focused heavily on the refractory bone infections of the foot due to the growing diabetic population. Refractory refers to a persistent bone infection following a completion of goal-directed antimicrobial regimen. Pre-existing microangiopathy prevents adequate perfusion to meet the metabolic demands required to manage these infections. Using a systematic approach, we decide the following. Is lower limb amputation prudent? Should the patient live with a chronic stable wound in a palliative approach? Or should all efforts towards limb preservation be made? The functional status of a patient and their aspirations are crucial to making these decisions. Osteomyelitis should be confirmed on imaging or with biopsy existing in the same bone previously treated for osteomyelitis. Avascular necrosis. Aseptic osteonecrosis. This is defined as a reduced vascularization of a terminal vascular bed. We use the FICAT scoring system, which is used mostly as a AVN for the femoral head. All efforts are focused towards joint preservation. Other causes of AVN amenable to hyperbarics are sickle cell anemia, interferon-mediated therapy, chemotherapeutic agent side effects, and long-term sequelae of saturation diving. The opportunities for intervention with hyperbarics include the early stages of the disease with FICAT 1 and 2 scoring, where complete recovery can be achieved on imaging with pain control and functional improvement. The pre-collapse stage, FICAT 3 early stage, is basically buying time before a patient has to undergo a total hip arthroplasty. Using hyperbarics, we minimize the number of possible operations or subsequent revisions a patient might require. MRI is gold standard for early diagnosis and ruling out the causes that might mimic the presentation of AVN. MRI at initial presentation compared to various intervals following completion of HBO is a reliable gauge and a good measure of improvement achieved. This would provide an option to avoid the invasiveness of surgery. Proper staging of these patients with lifestyle modifications, avoidance of joint overload, weight reduction, and smoking cessation should all be first line during initial approaches towards management of these strategies. All right, urgent indications. Sudden onset sensorineural hearing loss is defined as an abrupt onset of unilateral hearing loss of at least 30 decibels occurring within 3 days over at least 3 contiguous frequencies. This is likely far underreported. The mean age distribution is 46 to 49 years, equal gender distribution, and approximately 4,000 cases annually in the United States. Most patients don't have a baseline audiogram, so the degree of hearing loss is defined by comparison to the unaffected contralateral ear. The UHMS advocates that patients with moderate to profound hearing loss of greater than 40 decibels who present within 14 days of symptom onset that HBO should be considered as an adjunct therapy. ENT referrals should include ruling out underlying correctable causes. The initiation of oral steroids followed by intratympanic injections are paramount, but should not delay concomitant HBO to achieve hearing restoration. The Academy of Otolaryngology Head and Neck Surgeons advocates for the consideration of HBO for up to 3 months following symptoms onset. All right, we move on to urgent indications. Decompression sickness can occur secondary to the body reaching a state of nitrogen saturation in the blood and tissues with rapid exposure to decreased atmospheric pressure. Large volumes of this inert gas inside the blood vessels can occlude arteries and damage endothelium, causing fatal outcomes. Venous gas is often benign and can be filtered off by the lungs and exhaled. However, the pulmonary capillary network can be overwhelmed with venous gas in sufficient quantity and allow bubbles to be arterialized, resulting in an arterial gas embolism. Venous gas can also cross into the left side circulation via any intracardiac shunts such as a PFO or a septal defect. AGE in sufficiently high volumes can occlude vessels, causing infarction. Small bubbles remain in circulation only for a short period of time, however, can initiate a sustained reduction in local blood flow due to endothelial injury. Adherence of leukocytes to damaged vessel walls can also mechanically occlude small blood vessels. HBO helps hyperoxygenate the blood and tissues, creating a gradient to offload retained nitrogen into the venous network. AGE can occur secondary to scuba diving, exposure to hyperbaric environments, introduction of air into the circulatory system during hospital procedures such as lung biopsies, abdominal insufflation, or during the insertion removal of centrally located lines. Myonecrosis. The Clostridium species is a gram-positive, spore-forming, rod-shaped organism. Myonecrosis can spread up to 6 centimeters per hour with fatal results if left untreated. Clostridium is endogenous to soil and our GI tracts. Contaminated wounds with traumatic fractures, high-velocity projectiles, such as bullets or MVAs, that compromise the local circulation, or surgeries that involve our GI tract. This is considered a surgical emergency as debridement is our first line of treatment. Physical exam can reveal crepitus or dishwater drainage. When a combination of hyperbaric oxygen, antibiotics, and surgical debridements are used together, the mortality is significantly lower. Referred to as an intoxication resulting from the exposure to the exotoxin produced by Clostridium. This causes a severe inflammatory response with subsequent myonecrosis. HBO increases the partial pressure of oxygen to inactivate and prevent reproduction of the further spreading of alpha toxin. This provides ample time for our surgical colleagues to serial debride necrotic tissue. Necrotizing soft tissue infections. Progressive bacterial gangrene is generally a slow advancing infection that spares the deep fascia or the fascial plane that surrounds the muscle compartments. Necrotizing fasciitis is a progressive, rapidly spreading inflammatory process located in the deep fascia and secondary necrosis of the subcutaneous tissue and skin. This includes Fournier's gangrene, where the infection can attack the genital region and most commonly noted in our diabetic patients. This is a similar approach to our surgical debridements, culture-directed antimicrobials, and HBO. Treat the cultures with susceptibilities and speciation-directed antimicrobials. Central retinal artery occlusion. This presents as sudden, unilateral, painless vision loss. The retina has one of the highest rates of oxygen consumption of any organ in the body and is extremely sensitive to hypoxia. This is considered an ophthalmologic emergency and consultation is prudent, but oxygen administration should not be delayed. Visual acuity with no light perception may indicate a high level of ophthalmic artery occlusion and a lack of choroidal perfusion. This has a poor prognosis. Light perception and better visual acuity may indicate the presence of a collateral circulation via the cilioretinal artery. If present, a decreased but sustained perfusion to the retina can have a better outcome. Approximately 40 to 45% of the population has this collateral flow present. Admit these patients under a stroke protocol. Treat rare underlying causes such as arteritis, as those call for corticosteroids. If HBO can be started under 24 hours, that's good, but the sooner the treatments are initiated, the better. Intracranial abscess is rare, and mortality rates range up to 10% in the United States. Intracranial foci can result from bacterial, fungal, to parasitic infections. The expansive growth of the abscess and perifocal edema can result in secondary life-threatening increased intracranial pressure. HBO is adjunct therapy following neurosurgical abscess drainage and the initiation of culture-directed antimicrobials. The clinical course is guided by imaging and serial neurologic exams. This study shows data pulled from 7 series which revealed a marked decrease in mortality of intracranial abscess with adjunct hyperbarics. Hyperoxygenation potentiates leukocyte microbial killing while making the environment uninhabitable for anaerobic microbes. The elevated arterial oxygen tension results in vasoconstriction, leading to a decrease in cerebral blood flow, thereby decreasing ICP and the edema burden. HBO provides oxygen delivery to the hypoxic areas in the watershed zones, preventing further secondary brain damage. Carbon monoxide, colorless, odorless, tasteless gas whose poisoning results in 2,000 ED visits, 20,000 hospitalizations, and causes greater than 2,000 deaths annually. Carbon monoxide gas is produced by burning gasoline, wood, propane, charcoal, and other fuels. Heavy smokers can have an average carboxyhemoglobin level of 3 to 7% compared to the 1 to 2% in the non-smoker. Workers in the paint industry can accidentally inhale methylene chloride, an active ingredient in paint thinner, that can get metabolized into carbon monoxide in the liver, resulting in poisoning. The oxygen carrying capacity of blood is decreased due to the formation of carboxyhemoglobin that has a 200 times more affinity for hemoglobin than that of oxygen. Carboxyhemoglobin causes a leftward shift of the oxyhemoglobin dissociation curve. Most common physical exam findings are tachypnea and tachycardia. CO is cardio and neurotoxic. We see ischemic changes on EKG, elevated troponins, neurologic deficits such as ataxia, cognitive delay, and loss of consciousness. The body converts to anaerobic respiration with a byproduct of lactic acid. Profound acidosis is an ominous finding. We treat hyperbarics to minimize the development of delayed neurologic sequelae. This can develop over days to months following exposure. Cognitive symptoms such as aphasia or apraxia, motor deficits such as gait disturbances, and affective manifestations such as insomnia, dementia, personality changes, aggression, and psychosis. The ultimate decision to treat a patient with 100% normal baric oxygen at a local hospital versus transfer to a hyperbaric capable facility is situation dependent. The community, length of transportation, weather, available staff, and the severity of symptoms must be considered. An on-call hyperbaric physician, toxicology or poison control can assist with making this determination. A pregnant woman usually has a 10 to 15% lower steady state volume of carboxyhemoglobin than does the fetus. Fetal hemoglobin has a much higher affinity for carbon monoxide than the hemoglobin in the adult. So the more severe the maternal exposure, the higher likelihood of a poor fetal outcome. Acute arterial insufficiency. The primary role of HBO is to counteract tissue ischemia. Without adequate oxygen, the tissue is unable to meet metabolic needs. The result is non-healing wounds, non-functional tissue, necrosis, and increased chance of developing an infection. Oxygen diffusion is decreased due to edema, which increases the distance from the capillaries to the cells. Once the interstitial fluid pressure exceeds the capillary perfusion pressure, the capillary bed collapses. The flow in the microcirculation ceases, and the oxygen supply to the cell is disrupted. This is the pathophysiology that defines compartment syndrome. We treat traumatic ischemia injuries with HBO, primarily to hyperoxygenate the blood and other tissues. Secondarily, for vasoconstriction, which will reduce blood flow into the area by approximately 20%, preserving the outflow, which helps aiding in edema reduction. Compartment syndrome occurs when there is an ischemic injury to the muscle due to an interruption in the blood flow, causing edema and tissue hypoxia. This is a case of an elderly patient following an embolic event during an endovascular repair of an aortic aneurysm. Limb preservation was successful in this gentleman, which preserved his ability to live independently. Compromised grafts and flaps. A flap is a tissue transferred with its blood supply intact. The survival of a graft is a transfer of a tissue without its own blood supply. So the survival of the graft depends entirely on the blood supply from the recipient site. Compromised tissue becomes hypoxic due to decreased circulatory flow. So hyperoxygenation of these tissues stimulates fibroblasts, enhances collagen synthesis, while adequate circulation can be reestablished. HBO improves leukocyte function, therefore reducing in surgical site infection, and a decrease in peripheral edema improves skin flap adherence. So HBO is effective to reverse the ischemic penumbra following surgery. It helps support marginally perfused or hypoxic tissue to develop granulation tissue while accelerating angiogenesis. Optimal if started as soon as the flap compromise is detected. This is a patient who presented several days following a prophylactic bilateral nipple-sparing mastectomy due to testing positive for the BRCA mutation. She had a great outcome in just 19 treatments. Exceptional blood loss anemia is related to the massive loss of red blood cell volume. This can occur through exsanguination, hemolysis, or faulty production, which markedly decreases oxygen carrying capacity. Hyperbarics offers a way to clinically address life support when transfusion is not feasible. HBO also offers a solution in less common events, such as when transfusion is not viable, secondary to transfusion reaction, or those who decline, such as Jehovah's Witnesses. Burns compromise the microcirculation, resulting in ischemic necrosis followed by edema. HBO is valuable in thermal burns due to halting the thermal spread while aiding in the migration of stem cells to the injured area. Hyperbarics increases survival for burn victims while offering substantial enhancement in their wound healing and quality of life. Treatment should begin as early as initial resuscitation, as this will provide a reduction in patient morbidity, mortality, and length of hospital stay. This is a frostbite case with a good outcome after 1 month of treatment. Once again, thank you so much for being here today. Please feel free to stop by. I'm at a table outside to house any questions. Thank you so much for your time.
So Dr. Kessler knew that was a lot of material to get in such a short period of time. Any burning questions? So, as mentioned, he's made himself available all day for any of those that have questions. I know my medical school training, I knew one thing about hyperbaric oxygen treatment, and that was the bends. Outside of that, I had no idea what hyperbaric oxygen was used for. So, as you can see, many, many more indications. So, this is a man with a passion for hyperbaric and wound care medicine. So, if you have any questions, please hunt him down today. Again, thank you, Dr. Kessler.